My name's Lorie Pella. I'm with Humber River Hospital in Toronto, Canada. And we just finished constructing a replacement hospital. And we've been in this hospital for about just over a year. So October 18th of 2015 is when we moved in. So when I was asked to do a presentation on innovation, I thought, well, I better write some ideas down and write a definition and see what that comes up with. And then I did what everybody else did, go on the internet to see how it compares. So I thought this slide was very good because I can stand right underneath it and the light bulb's over my head. It's got all those words and it looks kind of cool. Then I Googled Wikipedia and it gave me a definition here. And but it talks about new ideas and how you apply them, but it doesn't talk about other things. This seems to be missing some items, like how do you take old ideas and reapply them, or even more importantly, the most important part is the people. You put them in a crucible and you come up with an idea. So just a few weeks ago, I was watching Netflix, and Steve Jobs' Lost interview, and he was talking about when he was 12 years old, he befriended a Hewlett Packard executive. The Hewlett Packard executive befriended him, and one day he took a bunch of stones, put them in a drum, and he tumbled them with some fluid. Next day he comes back, they crack open the drum, and there's beautiful stones. So Jobs then talks about his product development team at Apple, and how they interacted in this crucible, and they came up with all sorts of ideas. And Macintosh was born. We know where that came from. So a little bit about Humber River. It's 1.8 million square feet, 656 beds, big population, 1 million, and 50 languages spoken by our clientele. So what are the ideas behind Humber River and how we put together a design that encompassed all the ideas of what we thought were innovative? And so there were three things: lean, green, and digital. These are the vision elements of driving our innovation. They're all integrated and they all informed each other for the ultimate purpose of providing patient-centered care. It's a really organic, because you can't tell where one ends and one begins. You also have to work with constraints within your approach. So you've got limited resources, money, time, and you have the social, environmental, and economic frameworks to work. It's not a free-for-all. You don't have billions of dollars like Elon Musk to put together something, a project. So lean. This is the first step. So how do you make a big hospital small? Well, some presenters talked earlier about reducing the steps, taking your workflows for staff and trying to reduce them, and then collect the data, then put it into your design. We also created this airport-style arrival where you drive up along this concourse, and there are about 5 portals of care, and then you say, Portal A, I've got fracture clinic. Portal B, cancer care. You drive up, you get dropped off, walk across the sidewalk, into a building, 30 feet, and you're in the clinic. So you're reducing steps along the way for everyone. And then, ease of access for wayfinding. We shortened the travel routes. We separated entrances for high-volume clinics because we wanted to, keep them apart so that it didn't feel like the stressful, busy place that you're trying to get away from. You want to heal, so that's a challenge. Green, as opposed to sustainable. Some of the things we did, kind of typical laundry list of things, but we took it to the next level. We reduced ventilation rates. We increased duct sizings. We tried to recapture as much waste as possible. We're in a northern climate, so a lot of our energy is in the wintertime. We took efficient equipment selection, intelligent lighting designs, green roofs, and dynamic glass. But one of the more important things that we found was energy efficiency was a key factor for our green strategy because it's such a huge cost for our for operations. So we worked very hard on an energy model, and we targeted 40% less than ASHRAE 2007 by cost. So this graphic kind of shows you where we saved that energy. Now, there's a whole story behind this particular topic because we've had a year's worth of data, and what we found is even though we haven't reached our target yet, we are the most energy efficient hospital in Canada at 42 equivalent kilowatt hours per square foot, which is, right now it's incredible. And most of the new facilities being built today are not even touching that number. It's the existing facilities that have been able to, calibrate their buildings, and they know what they have to do, but still, our target would be 100 kBTU per square foot per year. We're right now 145, and with about a year's worth of calibration to go in the building. Because being brand new, there are things we still have to tweak. There's a lot of tweaking and calibrating to be done. So, digital and automation. We called it ICAT, Information, Communication, Automation, Technology. And it encompasses a lot of things. The IP, everything is based off the IP network. We have, real-time locating services. They're all on a common network. Some of them we have even separated networks because of all the traffic that's occurring, wirelessly. We took a lot of traditionally disparate systems and tried to put them together and make them interoperable. And ultimately, we tried to use that strategy across everything we could think of. So, from a digital perspective, it's going to improve quality of care and patient safety. That's the key factor. Gives you faster diagnoses, gives you fewer medication errors, gives the caregivers more time to be with their patients. We're trying to get the best service and patient satisfaction. We're trying to increase efficiency and leaner operations, enhance staff work environment. People are mobile and connected, as we all know. Automation. A lot of things in this building are automated. We have robotic delivery systems. See that in the picture here. We have the picture of a Da Vinci robot where the doctor is sitting at a console with a joystick, and he's operating on a patient, trying to reduce the invasiveness of a procedure, and then, of course, shorten the length of stay. This is applied in pharmacy, box pickers, pill pickers, in the lab with the total automation system, the automation, robotics, pneumatic waste and linen delivery systems. Now, the pneumatic waste systems we moved away from it years ago in Canada, but they're coming back. I think we decided as an organization to go forward with this, and we were the first to kind of start that reintegration of some of these processes. I've got here a slide of dynamic glass. It's a unique, I put it in here because it's very unique. I know there's a couple of suppliers at the conference. We have a lot of it. We have 26,000 square feet. And it was very challenging for us to get our heads around this. And we never even had it in our specifications to begin with. We had integral blinds and in an insulated glass unit. But the design builder, because they're also providing 30-year facility management for our model delivery, hated it. And obvious reasons. They break, they're expensive, but since it wasn't included in our in our specifications, and the design builder tried to change our minds with this product. It took a lot of time, but over the course of several months where we did some research and investigation, we kind of thought, we're going to go out on a limb with this type of product. It seems to embody the lean, green, digital principles we had in mind from the beginning. And we haven't looked back, actually. It's turned out quite well. We've had patients that are happy with the use. I mean, they can control the glass tinting from their bedside. It also follows an algorithm, and that algorithm has a number of parameters that reduces glare, that optimizes the daylighting. The issue we had to get over was the privacy issues. No curtains, there are no blinds, there are no roller shades. So that was the initial drawback for us. But then over time we were convinced that this could work, and we went with it, and we think it promotes our infection rates. I mean, since we've moved in, our infection rates have dropped significantly. Part of it is to do with a number of strategies. One is the glass, single patient rooms, 100% outside air. These are all things that we've tried to incorporate into our model, and it seems to be working at this point. So it all really boils down to patient experience and satisfaction. So all the digital, the lean green digital, it really is an organic process. And it took us 15 years to get here, but we had a very small team, and each of those principles had a champion, or at least a number of people that really, took that on, and we all worked not in silos, but together, because we all know a little bit of everything else. But the champions of each one of those really took it on, and we owned it, and that's what really, made this all come together for our project. You're improving patient care and safety. Less medication errors because you're scanning and barcoding. You're trying to eliminate unnecessary procedures, which are costly and just not sustainable. You have environmental controls for the patient at the bedside, that they can control their lighting, they can control their glass, and they can control their temperature. They also, as an organization, we've allowed people to have access to their health care, their health record. And it's all on this IBT, Integrated Bedside Terminal. You just kind of click it, you get a passcode, and you get in there. Something that a lot of organizations haven't tried to do yet, but we think it belongs to the patient. It's their information. They should have it. Maximizing natural light and providing 100% outside air. These are all things that are going to help patients get well faster. Provides the visitors and community a place to feel good about. So the other part of it is staff experience. The digital aspect, you're trying to, again, we're talking about limited resources. You want caregivers to provide care, not administrative duties. So, the idea is that it frees up time for people to actually, take care of their patient, give them the best care. You want to reduce repetitive entries and duplication. I mean, that's always a problem, and it's part of the lean process that we're all going through. The transport systems in a big facility, pushing carts and portering and all that. I mean, those things, people get hurt. They're heavy. Hospitals, at least in Canada, we have a very high rate of injuries, back injuries related to, pushing carts, and, it's a very dangerous environment to start with. It's pretty demanding, so we need to also understand that. The connectivity provides live, up-to-date information to a mobile staff so they can respond to any given event, whether it's facilities related or whether it's to deal with patient issues. So we're trying to make improve life for staff as well as the patients. And of course, the visitor and community, we are a big stakeholder in the community. We need to be stewards of the environment. We need to make sure that, because we believe that the health of the environment is interlinked with the health of people and patients. So we want to set that example. We want to be a leader in that. We've got lots of landscaping, areas of respite for people to go out and enjoy the outdoors when it's not cold or snowing outside. And so all these things, work together to provide an excellent experience for their visitors and patients and whoever's coming to the building. And also the interactive wayfinding and information systems. I mean, people, you get into a big hospital and you're stressed out because you need to get to a place, and how do you get there? People sometimes don't read their signage properly. So it was very important for us to develop this airport style arrival, along with a lot of ease of wayfinding, separated entrances, less stress with too many people coming into one area and causing a lot of issues with crowding and bustle, where you really don't need that as a patient. So in the end, we're now in this building, and things are going really well. I mean, most of the systems are working. There's a few bugs that we still have to work out. I mean, earlier today, you're talking about older facilities where you didn't realize that was a problem, these fire drill type things. I mean, we've had some of those too. I mean, we had a brand new building, and sometimes there's so much complexity, you don't even know what's happening. We had an outage, 2 outages from the utility, and the first outage took 13 hours to get back on. The utility was only out 86 seconds. And then the last one was just a matter of weeks ago. The utility was out 9 minutes, and it took us almost 2 hours to get back on utility. And what we discovered was, we knew what we thought we had, but our utility provider had a different a view of how they were putting us back on the grid, and nobody seemed to understand that. So we're having a lot of moments where we need to really dig in to see what are the some of the unknown knowns, the known unknowns. That thing from I think it was Donald Rumsfeld who said about those things. So that's the challenge. I mean, now we're energy target's still not where it's supposed to be. We are the most energy efficient hospital in Canada, at least, and yet our contract is to be 20% more efficient. So that's going to take some time. It's going to take a lot of calibration of ventilation systems, the little tweaks that all add up to something far more significant in that regard. A lot of the automation systems seem to work well most of the time, but the AVG number 8, we don't have a name for it yet, but goes rogue every so often. It seems to have a mind of its own, and we're trying to figure out, why does it do that? I mean, all the other ones are doing okay. Is it upset at working in a hospital? Who knows? But we have all these little tweaks that, generally speaking, they work great, but there are moments where you think, yeah, that could cause a further, unintended problem that we got to wrestle to the ground, and wrestle it to the ground quickly before it becomes something more serious. So, I mean, we talk a lot about, all these systems. It's complicated, and yet, as one of the champions of the goals that we achieved, it's hard to separate yourself from the building because you've been working on it for 15 years, and this is something that it's not just you, it's your idea, and you've taken ownership, and we can say that if you ask any one of our team members, they'll tell you the same thing. So, and we're still there, and we're still working away, and it's like you own it, it's your building. So going back to the innovation piece, it's the people. You got lots of ideas, new ideas, you got old ideas, and then you put them together, and the ideas don't generate innovation. It's the people who can take them and work together and make them work with something, a higher goal in mind. And I think many people here kind of understand that, and we try to continue to move forward with as we continue to move on in the building, and hopefully we can even get better. So not just maintain what we have, but make it better. So thanks for having me. I can take a few questions. I have a couple of minutes.
Thank you, Lorie. Yeah, question here.
Yes, hi. This is Judy Kwasny from NIH. So I'm very fascinated with how you got your, what I would call unified communications technology system to work for everything from a building automation system to controls by patients in rooms. I mean, this is thousands and thousands and thousands of points and sensors and bringing together sort of the BAS, as we call it, building automation systems for the major infrastructure, plus the end user response type of things.
Yep.
How truly did you integrate this amazing, massive technology? I mean, how did you do that and have it work fairly well?
Well, I mean, it's a lot of people involved, and you're kind of pulling from, maybe I'll back up a minute. We have a P3 model in Canada, at least in Ontario, the province that we operate in. And the P3 model, the consortia, which is Plenary Health, they have partners. And these partners are, global partners. And, there are a lot of smart people working in this building. And when we put together our output specifications, we tried, through our process, develop a performance-based versus a prescriptive-based document. And, we had a lot of people who were well informed about those particular topics. And so we pulled, from the hospital, the ownership team, we pulled the people we thought knew the systems and the way to put this together in the best possible way. And we wrote a very aggressive and very difficult, challenging project. This is what our vision entailed. Then, it goes out to bid, and you have consortium, and in this case was Plenary Health who won it. I mean, they've got JCI as a facility operator, a global company. I mean, PCL is the design builder. They work throughout North America, I think even in Australia, a Canadian-based company. But, there are a lot of smart people working together, pulling in the same direction, trying to get it together. I mean, even with that in mind and taking the ideas and putting them into action, I mean, you get part of the way there, maybe 85 or 90%, and then the last 10% is all this stuff that, we have a dead zone. We thought we put enough points in, and we're missing one over here, and maybe that's why number 8 goes rogue every so often. So, I mean, that's the challenge. I mean, there's so many things that you can't deal with everything, but you can deal with most of it, and then you have the right people there to try to solve the problems as they occur. That's what we're doing now, so it's challenging for sure.